it psychosomatic. Okay, so that's it. I'm not going to continue more. I want.
Okay.
Go ahead.
So welcome to today's session, everyone. I'm Nicole Ammon. Thank you, Moshe, for that very thorough introduction. For the sake of the recording, let's go ahead and Moshe, do your didactic, and then we'll have everybody in the ECHO community introduce themselves after the didactic. How does that sound today?
That's fine with me, Nicole.
All right, we're just changing things, thinking on our feet real quick. So welcome, everyone. We'll put the EAT code in the chat, and Moshe, you go ahead with your didactic.
All right. So the title is, as you see, the role of suggestion in clinical settings. And why is it not moving? Ah, here it is, I think, yeah. So common myths about suggestion, as you see. One is that being suggestible, which means responding to suggestions, is a sign of mental weakness and gullibility. Another common myth, of course, reality is that is not so at all. Suggestion is the second common myth, produces results only under hypnosis. That is not so. The person doesn't have to be in a hypnotic trance or under hypnosis to get responding to suggestions. Another myth, only hypnotists can give results or produce results with suggestion. That's not so either. Behavioral or physiologic changes as a result of suggestion are short-lived. Ain't so. Reality is some people who respond to suggestion stay with it for a very long time, in some cases for the rest of their lives. And this one, the therapeutic interventions based on suggestion are primitive and show a lack of more sophisticated skills. That is not so at all. And some of this you'll find in greater details in an article that was published in 2010. The central role of suggestion in all clinical encounters was published in Neuropsychoanalysis. And I believe I sent it to you, Jamie, so you can share it with the rest of the group. Jamie, you did get it, correct? Okay, thank you. So why did this happen? How come, I'm trying to get rid of something here. I don't know how to do this. Okay. Oh, I have some stuff in the top there of my slide. Nicole, Jamie, please help me. And it's blocking all the top of my slide. I don't know how to get rid of that. Let's see, maybe I'll move it to the side here or to the bottom. Okay, I tried to move it to the bottom. Maybe this will work now. Okay, so how come suggestion acquired such an inferior and trivial status in the minds of so many clinicians, especially in the field of mental health? And the answer to that is found, interestingly enough, in a book written by Paul Wachtel in 1993, titled Therapeutic Communication. And he says, quote, that relegating suggestion to an inferior, primitive, and unsophisticated method compared to psychoanalysis was a lifelong aim of Freud. This may explain the prevailing negative attitude of many psychodynamic-oriented clinicians towards suggestion and its use as a therapeutic tool. So as you know, Freud learned to use suggestion, interestingly enough, from Jean-Martin Charcot, who was a neurologist practicing at Salpêtrière Hospital in Paris and using hypnosis to demonstrate a variety of suggestions that happen in patients under hypnosis with suggestion, like, initiation of, for example, of seizures or stopping seizures. Freud went there and watched with great amazement about this and went back to Vienna and tried to use it in his own work. And then he went again to France to learn how to use suggestion from another guy. His name was Hippolyte Bernheim from the Nancy School. So he was very much familiar with this and used it, but then he developed his own method of treatment called psychoanalysis and wanted all the people that learned to use suggestion to abandon that and go with what he called the gold standard of therapy, which was psychoanalysis, according to his view. and therefore he sort of talked down suggestion with the idea that the gold standard is really psychoanalysis and not suggestion. And many of the followers of Freud, including American psychoanalysts, followed that even to a greater degree. They refused even to learn the use of hypnosis and the use of suggestion in any way, even though they actually did, but they didn't believe in it. They believed in psychoanalysis and the use of interpretation as the main therapeutic intervention. Okay, moving on to the next slide. So what's the scientific basis of suggestion? I'll give you a quote here from an article by Raz on neuroimaging of suggestion. Dr. Amir Raz is the head of a special lab at McGill University in Montreal, where he studies with functional MRIs how the brain responds to different stimuli, in this case, neuroimaging of suggestion. And he says the following: suggestion and attention are central themes in cognitive science. They reify the links between brain and behavior and marry psychology with the techniques of neuroscience. And he goes on, suggestion and attention influence cognition, affect, thought, and action, unquote. So suggestion may affect biology. Here is another quote from Anne Harrington, very interesting lady from Harvard University. She wrote a wonderful book, which I highly recommend, called The Cure Within. And she says, multiple accounts corroborate the involvement of psychological parameters, including suggestion and expectation, in the modulation of biological processes. So suggestion isn't just psychological. Studies involving brain imaging and genetics have begun to unravel the neural underpinnings of suggestion and its underlying substrates. Again, coming from Amir Raz, McGill University, who is that expert on functional MRIs. Okay, so suggestion can be verbal and nonverbal. Nonverbal suggestions, just look at the example here: facial expressions, eye contact or no eye contact, physical touch or no physical touch, body language as a whole. So here is a common body language that some physicians use when they make rounds in a hospital. I've seen it many times. They say to a patient, do you have any questions? After they give their spiel of the diagnosis or treatment plan or whatever it is, the patient is lying in bed, the doctor stands there, and as he says, do you have any questions? What does he do? He takes a look at his watch, moves his hand, looks with his eyes at the watch, and then starts walking towards the door and says, do you have any questions? And what do you think the response of the majority of patients is? They say no. Why do they say no? Because they respond to the suggestion from the doctor, which is, I don't have any time for you, and starts walking towards the door. So the suggestion is, don't ask me any questions because I don't have any time to answer them, even though the doctor says, do you have any questions? That's an example of a nonverbal suggestion. Okay, verbal suggestions, you can see tone of voice, rhythm of communicated message, the content of the communicated message, the guidelines for living. We'll talk more about that as I go on. Okay, we're going to do now an experimental exercise about suggestion. And it's not going to take long. It's just 2 or 3 minutes. And if you don't want to participate, you don't have to. But those of you who are intrigued, I hope you will be willing to participate, because you're going to learn something experientially. As you know, a lot of the presentations that people do use slides, and most of them have to do with what's called cognitive learning, acquiring new knowledge cognitively. Here, I'd like to do a new experiment with you, where you are going to acquire this knowledge experientially. You're going to experience something, and you'll remember it in an interesting and different way. So here we go. I'd like you to focus on the following suggestion I'm going to give you. Okay, ready? Don't think about a rhinoceros. Listen again, don't think about a rhinoceros. Notice what happened. And I bet you can raise your hands. How many of you thought about a rhinoceros? Majority of you. Yes, if not all. And how did this happen? The instruction was, don't think about a rhinoceros. And what you got is the opposite of what I asked you to do. So that's an interesting way of giving a suggestion in a negative way. So the idea is for you to not to think about a rhinoceros when actually the end result is you did. And the other interesting element about all this is that you did not intend to do this. And we'll talk about that in a moment in greater detail. So here are some common suggestions using a similar method in clinical settings. How many of you have heard clinicians, mostly in the hospital, but even in outpatient settings, quote, don't worry, this is not gonna hurt, quote, okay? And of course, what do you get? Like, don't think about a rhinoceros, don't worry. People worry more because the unconscious mind doesn't understand don't, it doesn't get it. When you say don't unconsciously, what is internalized is worry and hurt. Or this one, we do this procedure a lot, you are not gonna die from it. What do people internalize? Die. This is not serious. I don't think it's cancer or anything like that. What do people internalize subconsciously? The words are serious and cancer, even though the doctor said, I don't think it's cancer. Next one, you don't have to lose any sleep over it. Most people are not upset about it. All right, so lose and upset. Or this one, you will have some pain after this procedure, but in most cases, it does not last for a long time. What do people internalize? Pain, long time. Pain for a long time. Okay, next. Most suggestions are not intentional. That's very important to remember. So most suggestions are given in a way that's not intentional by the one who is using it to influence the patients. And these suggestions are embedded as part of a regular standard conversation with the patient or among healthcare professionals that the patient happens to listen to. So, example could be the doctor makes rounds with residents, this is in a hospital setting again, and medical students, and talks to them about something that they should observe with this patient, with this rounds. And even though the doctor talks to them, not to the patient listens in, and something happens as a result of that. So here are two interesting examples. They are taken from a book that was authored by Norman Cousins, and the title of the book is The Healing Heart. In it, Dr. Cousins asked one of his people that he admired a great deal. The man's name is Dr. Lawn, and Dr. Lawn was professor of cardiology at Harvard University School of Public Health. And he wrote about his own experiences with suggestion in this case. And you can read about it in this introduction if you want to, but I'll tell you briefly about these two cases he mentions. First case is that of, this is from the early 60s, late 50s. This is a woman that Dr. Lawn was treating at the time because she suffered from mild congestive heart failure, and the medications that are available today and then are very different. The treatment options for congestive heart failure at the time was quite limited with medications and with diet and so on. And Dr. Lawn took his time and treated her conservatively. And she did quite well in the sense that she stayed stable enough to continue to go to work. She was in her late 50s and stable enough, trusting him a great deal because he got out of the hospital. She had an attack of pulmonary edema, which is, as you know, an acute state of congestive heart failure. He got her out of that and was able to stabilize her. And she would come and see him every 3 to 6 months on an outpatient visit. And he listened to her, looked at her medications, took her blood pressure, her pulse, sometimes did an EKG, reassured her, was very pleased with how well she was doing. And she would leave that visit with a great deal of a sense of hope and confidence and comfort with his reassurances. Okay. One day she comes in for that follow-up visit, but this time Dr. Lawn has with him fellows in cardiology, residents in internal medicine, and medical students. So a whole entourage of people. And he examines her as usual. And in teaching them, the fellows in cardiology, he wants to teach them how to listen well to the heart with a stethoscope and identify what was the case in her situation. She had what's called tricuspid stenosis. Now, what is tricuspid stenosis? As you know, in the heart, we have 4 different valves. One of them is called a tricuspid valve. It's a valve that is between the right atrium and the right ventricle of the heart. So this is where the blood flows from the lungs into the right ventricle of the heart. So the valve there is called the tricuspid valve. Now she had tricuspid stenosis, which in cardiology lingo, as you know, physicians use a lot of medical lingo. He just used the term, instead of saying tricuspid stenosis, he used the lingo that was common there with cardiologists, TS. Okay, so he says to his trainees in cardiology, this is a very important opportunity for you to listen to TS. Listen carefully so you will learn how to identify it in the future. So this is a classic case of TS, he says to the fellows, and walks out. So they all gather around her with the stethoscopes, and each of them takes his time to listen to the sound of tricuspid stenosis. And as they do that, she begins to breathe more rapidly and says she's not feeling well. And they take her blood pressure, they, take her EKG again and so on. And even though they say we find everything to be, not different than before, she gets worse. Now, not only is she becoming short of breath, but her heart rate goes up, her blood pressure also goes up, and they don't feel comfortable letting her go home from this outpatient visit. And eventually, she becomes so short of breath, and they listen now to her lungs, and they hear the classic, rumbles there in the lung that indicate she may be developing congestive heart failure in her lungs, the first signs of pulmonary edema. They decide to admit her to the hospital. So she is admitted, and as you know, they have to put oxygen now to give her an additional breathing, and they just don't know what else to do to help her, and she's getting worse and worse. One of the medical students then sits down with her to take a more deep, detailed history. What happened? What happened? And she tells him, to that medical student, that she believes she is getting worse because she heard Dr. Lawn tell the young, trainees that she is a classic case of TS. And he asked her, what do you mean? She says she understands TS to mean terminal situation. And they tried to get in touch with Dr. Lawn to reassure her. He was not available. There were no beepers at that time. Of course, no cell phones. They couldn't find her. 48 hours later, she was dead, and they couldn't help her. Interesting story. He meant TS, tricuspid stenosis. She understood it to mean terminal situation. Next one, the man with a galloping heart rhythm. This is, again, another story from Dr. Lawn. He is chief of cardiology. He makes rounds again with all his entourage of cardiology fellows and residents in internal medicine and so on, and medical students. And he is now seeing this man who is in his late 60s to early 70s, I believe. and he suffers from congestive heart failure. And they tried everything on him. He is with oxygen and all the medications they tried, and he's still not better. He's been in the hospital now for more than 2 weeks in the intensive care unit, and he's not better, and they don't know what to do. And Dr. Lawn identified with him a special heart rhythm, which is called in cardiology, as you know, again, lingo, the galloping heart rhythm. Now, the galloping heart rhythm typically happens as an early sign before the person goes into complete heart failure and then die. So this was meant to mean that this is a bad sign for this man, that he's not going to get out of his congestive heart failure, and his heart is about to totally fail and he will not recover. So he says to, again, the fellows in cardiology, please listen. This is a good example for you to identify a galloping heart rhythm. Listen with the stethoscopes. So he says to them, this is a classic case of a galloping heart rhythm, and walks out. And they, again, go around the patient with their stethoscope. Each one takes his turn, and they listen carefully and nod with their heads about identifying the galloping heart rhythm. The following day, Dr. Lawn makes rounds again and asks this guy, how are you feeling? And the guy says, I actually slept well last night for the first time in a long time, and I'm feeling a little better. And every day as he makes rounds with this person, he gets responses, I'm feeling even better and even better. So they take off the oxygen, and still his breathing is much better, and he's getting, every day he's getting better and better. And about 10 days later, he's feeling so well, he starts walking, on the unit without oxygen, and they let him go home, discharge him. And they're all amazed by, how did this happen? So about 2 months later, he comes for a follow-up visit on an outpatient basis with Dr. Lawn. And Dr. Lawn asks him, how have you been feeling? And he says, oh, wonderful. I feel so much better. I can do things in the garden now, which I didn't believe I would be able to do. I don't have to use oxygen anymore. And Dr. Lawn is absolutely amazed, because he didn't change anything with the medications. Like, he says, what do you think happened here? What helped you to get you to feel better? And the man says to Dr. Lawn, Dr. Lawn, I know exactly what happened, and I can even tell you the exact day when it happened. And Dr. Lawn says to him, yes. So he tells him, do you remember that day when you went and you made rounds, in the hospital with all the young fellows in cardiology that you were training and so on? And you examined me, and you said to all of them, you pronounced the fact that I have a galloping heart. And from that, I took it that my heart is as strong as the heart of a horse galloping. And I knew I was going to get better. So the patient's explanation from that, now Dr. Lawn did not mean to give that suggestion, but the patient listened to that and took from that he has a heart that is as strong as that of the heart of a strong galloping horse. Isn't that interesting? That's the patient's own perception, as Dr. Lawn learned then from him. He then wrote a whole book about suggestion and how cardiologists can practice that. So suggestions are given many times embedded in suggestions. For example, have you recovered from this episode before? So adding the word before gives the suggestion that what? That it's going to happen again now. Have you been hypnotized before? So if the patient says yes, that means they'll be hypnotized now again. If they say no, that again means they'll be hypnotized. So typical Dr. Erickson, who's a famous physician that was using a lot of hypnosis and teaching it, would use that term, have you ever been hypnotized before? Have you ever taken prescribed medicine that helped you get well again? So what's the suggestion in there? That medicine helps you to get well again. Which positions in your elbow create discomfort? So what is the essence of the suggestion there? Notice the word discomfort. Now, why is that important? Because instead of saying the word, which positions in your elbow create pain, in this case, the word pain was replaced by the word discomfort. And the patient internalizes the suggestion of what? Comfort. Because remember, the unconscious mind doesn't understand discomfort. It only internalizes comfort as the core word. Were you informed that your condition is terminal? What does the patient then internalize? The suggestion is what? Terminal. Did anyone in your family die from cancer? What does the person then internalize? The suggestion is what? Cancer. Since when have you had this severe pain problem? All right. Again, what's internalized is severe pain. Therapeutic suggestions, examples. So here's one example, quote, later, when you remember this visit, you may also recall how good it feels to be so relaxed again, just like you did on your Florida beach vacation. As you look at these pictures at home, you may want to write about it in your journal and bring it with you to the next session, unquote. So this is actually something I used with a patient who I taught relaxation exercise, and they attached it to a specific time when they went to a Florida beach vacation and were able to recall it, experiencing it with all their five senses, visually, auditorily, sense of touch, sense of smell and taste, and so on. And what I do is I give them a suggestion that they will experience this at home as they remember this session, this visit, and later on write in their journal. This was a patient that liked to journal a lot about her experiences. So she will write about it. She brings us to the next session and she reads to me out loud what was written in the journal. Or this example, as you take this medicine at home, so this is a patient that a new medication was prescribed to, you may soon experience a sensation of dryness in your mouth. This will be your signal that the medicine has begun to work, unquote. So I use this suggestion quite often when I prescribe a medication that has a side effect of dryness. Anticholinergic side effects are quite common in many psychotropic medications. And that side effect begins far sooner before the actual therapeutic effects, as studied by scientific studies, begin. In many cases, 2 or 3 weeks later. But side effects begin a lot sooner, in some cases, even within a day or two. So what do I do here? I give a suggestion, but I also internalize or integrate with the suggestion an element of reframing. So what am I reframing? I'm reframing a side effect to actually give the patient a sense of hope and make it a therapeutic effect. So what do? I say, you may experience a sensation of dryness in your mouth, and this will be your signal that the medication has begun to work. This is all true, as you can see, but I reframe it for the patient to what? To have trust and belief that after this has begun to work, the other effects will also happen, which are the therapeutic effects. Okay, other clinical examples. A clinician, upon prescribing a new medication, says this: I have to let you know all the possible side effects that may happen with this medication. If you develop any problems, please call me. So the doctor lists a whole list of side effects and then says to the patient, if you develop any of these problems, please call me. By the way, where did I learn to say this? I learned it in medical school. I watched many physicians say this, outpatient visits, many, primary care physicians and so on, even psychiatrists. And guess what happens? In most cases, people call to report problems with any of those lists of side effects. What the amazing thing about these side effects is that when we do studies checking a new medicine against placebo, and we list with a placebo all the possible side effects that could happen with the actual medication in double-blind studies. And guess what happens? People actually develop side effects of the placebo, which is fascinating. But again, it shows the example of what? The influence of suggestions. So instead of saying this, I used to say this, by the way, If you develop any problems, please call me. I said to myself, what can I do? How can I develop a suggestion here that would give me the opposite? So I came up with this. I say, many patients have reported feeling better with this prescription, even in the first week. That is actually true. I've had many patients that do that. And I say this, can you please promise to call me even if you begin to feel better? And I asked them to promise me. And many patients responded and said, yes, Dr. Torm, I promise to call you. And we shake hands. Guess what happens? A week later, I get a phone call and they call me to tell me no, that they have begun to feel better, which is wonderful. Now, some people may say, oh, this is just placebo. I say, what the heck? So what if it's placebo? As long as the patient begins to feel better. So I don't poo-poo it. I had patients before I started using it that actually would tell me that they started to feel better within a couple of days after the medication was given. And you know what I did? These are mistakes I made many, many years ago when I was a resident. I would say, that's not possible. You're supposed to start feeling better only in 3 weeks from now. No, that's not possible. And then I said to myself, why am I saying that? They feel better, it's wonderful. So I was told by some of my supervisors, oh, Dr. Torm, it's only placebo. So now I say, only placebo? Let's get going with it. It's wonderful placebo. I'd love to have a lot of good placebo too. Okay, next, more examples. Hospital nurse to a patient after surgery. Quote, I actually heard that being said in the hospital. Do you have any pain? Mr. Jones will call. Mr. Jones, do you have any pain? No response yet. The nurse goes on. We have strong painkillers, you know. In our program, we make sure you don't suffer any pain. Are you sure you don't have any pain? Unquote. Okay. So how many times has the word pain been used? So even if the patient doesn't have any pain yet, what are they going to internalize? They'll internalize what? Pain and painkillers. So what's the other option here that may be more therapeutic as a suggestion? Instead, how are you feeling, Mr. Jones? How was your sleep last night? Do you have any discomfort? So what have we done here? We have replaced the word pain with what? Discomfort. And what is being internalized out of that? Comfort. Okay. Please let us know if any discomfort you may feel. We are here to help you stay safe and comfortable so your healing proceeds smoothly, unquote. I actually taught nurses at the hospital to use that or some other modification of it, and the results were astonishing. Okay, next, examples for mental health settings. Therapist in the first session says to a patient, quote, you said that you came to me because you have heard that I cured many people. Well, I want to let you know that I can't promise anything. There are no guarantees here. Some people initially get worse, actually. And besides, I don't want you to idealize me. I'm not perfect. I have my own flaws. So a lot of it depends on you. Only you can make yourself better, nobody else, unquote. So imagine, okay, how many suggestions have been given here that are actually anti-therapeutic in nature, as you can see from a statement like this. All right, therapist to a patient in the first session, quote, you sound very depressed to me. Have you ever considered killing yourself as a solution to your problems? Unquote. Actually heard a psychiatrist say this, okay? A resident of psychiatry, okay. Resident psychiatrist in training. Instead, consider saying this. You said that you have been feeling hopeless for a while. You have tried different ways to get yourself better, and you have not yet found an effective way to solve the puzzle. I'm impressed with your determination and perseverance. I believe that together we will find new and creative and practical solutions to get better. So notice what's the essence here of suggestions that are being internalized. One of them is what? Right in the first sentence, is being said the word hopeless. Okay, instead of using the word depression is replaced by what? Hopeless. So what's the essence here in the word hopeless? We take the word hope, which is a core positive word, and we add a suffix to it, less. And what does the subconscious mind internalize? Not hopeless, but the core word, which is hope. Remember, like with the word discomfort, the core word is comfort. And what is added to the core word comfort is the prefix dis. So discomfort, and here hopeless. What's internalized is hope. The second thing I want you to notice is that you have not yet found an effective way. So I throw in the word yet deliberately to imply what? That we will in the future find it. So not yet found, but will be found in the future is the internalized suggestion here. Okay. And of course, the last two lines are sort of obvious in their suggestions. Okay, there is another element here, which is what? The togetherness. We will work together. So it's a subtle way of inviting the patient to participate in finding the solutions. And that the patient and the doctor together are a team. We can say the clinician, the therapist, with the patient, the client are a team together. Okay, so a couple of words about something, the difference between autosuggestions and heterosuggestions. Heterosuggestions basically, as you see here, mean what we internalize for messages communicated to us, verbal and non-verbal, from others, okay? Autosuggestion is what we do here, what we hear in our mind, and the word here is H-E-A-R, that's a spelling mistake, okay? In our mind that we say to ourselves. So when we talk to ourselves quietly, or what we sort of hear subconsciously of what is being said to us. So here are some examples. But before we go to the examples, the idea of autosuggestion being used as a therapeutic intervention was introduced in the United States by a French man by the name Emil Kuwei, who lived between 1857 and 1926. He was a psychologist and a pharmacist, interestingly enough, with an interesting combination. He traveled to the US after being successful in Paris and France, and he came to the United States in 1923 and gave many lectures on autosuggestion that were open to the general public. So he didn't just give it to professionals in mental health, but to the general public. And he became a real celebrity here. Then it went back to France. But one of the things he was famous for is the following translation from French to this: every day in every way, I am getting better and better, unquote. And people were instructed to say this out loud in large groups that came together to listen to him. Okay, so people who picked up on that idea, just to let you know, developed the whole idea of what's called optimism and positive thinking. One is, of course, Vincent Peale, who wrote a whole book about positive thinking, and Martin Seligman, who developed a whole center for optimism and positive thinking in Philadelphia, PA. He will celebrate next year his 80th birthday. Okay, so treatment outcomes, pretty clear. People with positive expectancies of treatment generally do better than those with negative and pessimistic attitudes. Okay, here are two other people that developed this whole idea about what to believe and using suggestions and internalizing them. Interestingly enough, one is David Spiegel, who is the director of the Center for Integrative Medicine at Stanford University in Palo Alto, California. He wrote a book titled Living Beyond Limits. So what he did is, together with a bunch of others, did a study on patients with breast cancer with metastases in several places in the body who have not been able to reach a remission. in spite of the treatment. And he gave them group therapy and taught them the use of self-hypnosis with other suggestions. And then compared them to another group of patients with breast cancer and metastases who did not receive that. And what he found is not only did their quality of life do better, but they actually lived longer than the people in the other group that didn't receive this. And based on that, he published an article in The Lancet, and he also wrote a whole book, which is titled Living Beyond Limits. Those of you interested can get it. It's still available for sale. Fascinating, fascinating story. The other one is the book titled The Biology of Belief by Bruce Lipton, PhD. Fascinating book, again, showing all kinds of interesting aspects of how what we believe and what we say to ourselves affects us, not only our thoughts and our feelings and behaviors, but also our physiology. Okay. Right. So here are some more examples, I believe. Let's see here. Gotta move this down. Okay. The power of suggestion. Reframe the information about side effects. We talked about that. And when you begin to experience a dry mouth, I mentioned that to you, most patients do well with this prescription. I mentioned that before. Some patients begin to experience improvement even the first 3 days, mentioned before. When you feel sedated, this is for a patient that the medicine is used at night to help them sleep before you fall asleep. That means that your brain is responding well to the medicine. These are all examples of suggestions here. Let's see. Okay, when the patient responds improvement, let's say I say to a patient in the second or third session after the new medicine is given, the patient reports feeling better. I consider saying to some patients, what have you done differently to make it better? To invite them to take some ownership of feeling better. I give them assignments to record measurable observations of their progress by focusing on expected desirable outcomes. So for example, hours of sleep, hours of having more energy, ability to do some things that they felt they couldn't do before, whether it's taking a walk, counting steps. And today, you know, with cell phones, you can actually record your walks, you're walking, taking walks daily and counting how many steps you've taken. So stuff like that, that's easy to record. And instead of losing weight, I help them to reframe it and say something like achieving healthy slimness rather than losing weight, because people don't like, the unconscious mind, I would say, internalizes losing with weight. And that's something which is generally applied negatively. So instead, we talk about achieving healthy slimness and gaining units of healthy slimness. So that's another example of reframing. Okay, so in summary, guidelines for suggestions. Be clear, specific, confident, be positive and affirming. Instructions should be believable rather than not believable. And be gentle and kind, and use believable imagery. That's very important too. So an example, I don't use imagery of flying like a bird as an example. But instead, believable imagery is something that a patient may have experienced before, like your last trip to Florida, or your previous trip to the Florida beach as an example, in the middle of winter. Do you remember what you experienced there? Describe to me what it was like. Do you remember seeing the skies? Are they blue and clear? Is the sun shining? So I sort of encourage them to describe what they experienced, and that becomes more believable imagery. Summary. So avoid negatives. You can see already clearly, like don't be afraid, don't worry, you won't die, this won't hurt. Okay, avoid blaming, avoid instilling doubts in patients, like I doubt this will work. I actually heard some people prescribing a medicine, well, I don't know what else to do. If you want, I can give you this new medicine. I don't believe it's going to work, but what else can we do? We have nothing else to do. So anyway, so let's do it. So the introduction is like all this negative things about it, but the doctor goes ahead, prescribes the medicine anyway. So avoid doing that. So avoid these core words: hurt, pain, bad, suffer, die, and so on. Avoid poor prognostications, and avoid the word try when you want someone to act. Instead of trying, try doing this, actually help the patient describe what is it like to actually do it. All right, and so here are examples. Instead of don't worry, stay calm, relax, calm, and confident in your doctors, or instead of don't be afraid, you can feel safe knowing that we are here to care for you, and so on. So it's pretty self-explanatory in this summary. And here we are. Thank you, and let's have a discussion.